Hi guys, welcome back. The next topic we're studying is cardiomyopathies. I'll be explaining to you relative the more common variety, that is hypertrophic variety. First and the foremost, I want you to remember that in lot of books you will read the term written as HCM and sometimes it is written HOCM. HOCM would signify a dynamic left ventricular tract obstruction. I'll explain to you in a while what I mean by the word dynamic left ventricular outflow tract obstruction, but at the moment I want you to remember the fact that 70% cases would be having obstruction present, the remaining 30% will not be having any obstruction present. So we are mainly going to focus on the obstructive component of the disease as we progress. The pattern of inheritance of either of the two forms, whether he writes HCM or HOCM, is autosomal dominant. There is close to about 30 genes which have been ascribed per se for development of this disease, but I am going to mention the one which is relatively more common, that is beta myosin gene, or very commonly written as MYH7 gene. Now this would be sitting on chromosome number 14, though you might hear that while I'm taking the discussion, I might even say chromosome 11 is involved in HOCM. Yeah, because there are multiple genes and multiple chromosomes involved. So I have here highlighted the one that's a must know for you, the one that is relatively more common, that is defect on chromosome 14, and this particular gene results in pathogenesis of this disorder. And now I have a line diagram which I'll explain to you, in which the manifestations of the disease will become relatively more easier. Though there's a printed diagram already on the slide, but instead of just focusing or drawing arrows on the printed diagram, I would like to hand draw before even explain why the disease is going to have its ramifications. The first and the foremost problem of these patients would be a presence of a septal hypertrophy, and you can see this is useless muscle. I mean, it will not contribute anything to the cardiac contractility. It's not gonna make the contractions more powerful. All this muscle will do is consume oxygen, and this explains the subendocardial ischemia component of the disease and why chest pain develops in these patients, because the heart is bigger, the demand is more, but the size of the coronary arteries remains the same. In fact, in these patients, there will also be a significant free wall hypertrophy as well. In fact, I'll tell you the cutoff for diagnosis of HOCM also, and when sudden death can also occur, because there's a tremendous increase in oxygen consumption. But at the moment, you can definitely notice that the shape of the left ventricle is distorted, and at the same time, even the size of the left ventricle, when you compare with a normal individual, is substantially reduced. The problem in this patient is, however, not at the level of the aortic valve. You can very well see the problem that is present in the heart of this patient is below the level of the aortic valve. So you will always read the term subvalvular aortic stenosis. Let's take out these problems one by one. First and the foremost, I want you to remember that though I began the discussion by saying that this is a hypertrophic obstructive cardiomyopathy, please appreciate that because the size of the left ventricle of this person is much smaller as compared to normal individuals, so less blood will come in the heart, and if less will come out, then less will obviously go out also. So the primary defect in this question, or the primary defect in the MCQ, will be answered as diastolic malfunction. I repeat that again. Yes, I agree, this condition will also have a systolic malfunction, but the primary defect is a diastolic malfunction. And along with that, I've already highlighted there is a asymmetrical septal hypertrophy, which is not going to contribute anything to the contractility of the heart because of the position per se, but it will definitely increase the oxygen demand, and therefore the chances of these patients suffering from even arrhythmias due to hypoxia can dramatically be increased. Lots of time in MCQs, instead of writing the word HOCM, as I explained, the problem is below the valve, so he will write the word subvalvular aortic stenosis. In fact, in these patients, over and above whatever I have described, there can be an additional defect present, which is usually visualized on echocardiography. Just look at the position of the mitral valve leaflet. These are the mitral valve leaflets you can see. This would be the left atria of the patient. There is a systolic displacement of the mitral valve as well. In fact, this is one of the important echocardiographic findings of this condition that I'm talking about right now, because this is a very good pickup point in the MCQ. When you read a question that is talking about subendocardial ischemia and presence of systolic anterior movement of the mitral valve, I mean, the word that you can use here is SAM. SAM per se again explains that in these patients there would be an outlet obstruction. How? Just look at the aortic valve orifice. This is the aortic valve orifice. Above this is the aorta. You can notice that the problem in these patients is not in the valve. The problem lies much below the valve. This is the hypertrophied septum, and you can see this very narrow funnel. In fact, I'll just highlight before you. There's a very narrow tunnel present. I can call it funnel or I can call it tunnel. Through this tunnel, the blood has to eject into the aorta. Compare this with yours and mine. Absolutely no issues. I mean, this is the aortic valve leaflet. The blood can straight away race into the aorta, but in these patients there's this tunnel present, which is created due to two reasons. One of the reasons for this tunnel being created is the septal hypertrophy component, and the second is the systolic anterior movement of the mitral valve. The combination of the two creates a funnel slash a tunnel through which blood has to eject out into the aorta. So that is what I meant by the word dynamic, because blood is going out of the heart. This is dynamic left ventricular outflow tract obstruction present in this condition, and the free wall of the heart of these patients is anyway hypertrophied or is much more significantly increased in mass. In fact, the free wall of the heart of these patients can be as much as more than 15 millimeter. That is, in fact, one of the diagnostic criteria for this condition. I want you to remember that if the free wall thickness, please remember my words here very characteristically. If you notice in any question written that free wall thickness of the left ventricle is more than 15 millimeter slash 1.5 centimeter, it is suggestive of hypertrophic cardiomyopathy. I will also subsequently be talking about a case where the left ventricle free wall will be as much as 30 millimeter thick. Imagine, I mean, it's literally like thick as an armor. I mean, 3 centimeter thick wall of the left ventricle. So the amount of hypoxia is going to be tremendous. And when the diagnostic criteria is 15, but if it goes up to 30, then the chances of sudden cardiac death are dramatically increased in the patient. And to prevent this sudden cardiac death, what are we going to do is the main focus of this entire discussion. I mean, ultimately the question will boil down to that he'll give you a case of hypertrophic cardiomyopathy of the obstructive variety and ask you what is the main life-saving intervention that you as a physician, as a doctor can do to save the life of this person. Over and above this, we can also add a domain from pathology. If I just do a slight marking here, you will realize that the shape of the lower end or the shape of the left ventricle per se cavity is a little distorted. So in pathology, you will also read about this word banana shaped cavity of the left ventricle. I highlight once again since a lot of questions are integrated. So I just put on a pathological domain here. A banana shaped cavity of the left ventricle is a feature of HOCM. And the most important problem of these patients would be enhanced left ventricular free wall hypertrophy, which if to the tune of 30 millimeter is present, then the incidence of sudden cardiac death in these patients is dramatically increased. Now, on the basis of this background information that I've described before you, for the one of the common type of cardiomyopathies that is asked in exam and seen in clinical practice, we are gonna actually look at how the case would evolve. The usual age of presentation of this disease would be something between 10 to 20 years of age. I'm describing a male patient here, can be a female patient as well, and the earliest manifestation and the commonest presentation of these patients is breathlessness. Now, why breathlessness is occurring in this case is one, because most cardiology cases present with breathlessness, but in this case, the main reason is diastolic malfunction. You see, the hypertrophy of the left ventricle will ensure that there will also be a correspondingly increased pressures in the left atria. You see, most patients of hypertrophic cardiomyopathy develop a left atrial hypertrophy also, and if the pressure in the left atria will increase, then they, due to back pressure changes, they can be lung pressure that can increase or hydrostatic pressure in the blood vessels that can increase, and that can explain the pulmonary edema component that can develop in these patients. I can explain it a different way. Because of diastolic malfunction, there is a pooling of blood in the lungs, because after all, the pressures in the left ventricle in the filling part are relatively elevated, so blood cannot properly come in the left ventricle. If less blood will come in, automatically less will go out, but where will that remaining blood remain, or where will the blood pool? That would be in the lungs of the patient, because pulmonary circulation is fairly compliant. The pooling of blood in the lungs of this patient will explain the increase of hydrostatic pressure and a pulmonary edema component. So these patients will become breathless on any kind of physical activity, and in fact the performance of these patients in sports will always be limited. Like between 10 to 20 years of age, this boy, he's watching other boys in the colony play cricket, football, badminton, or any other sports per se, but this guy will always be missing out on all the fun of playing all these games, etc., or physical activity involving games, primarily because he's not able to match up to the stamina of his friends. In fact, his friends make fun of him because he's the slowest among them when it comes to running, because he feels breathless. And in fact, they were teasing him further because when he tried to run as fast as them, he started having having even chest pain on exertion. This chest pain is explained by the subendocardial ischemia component and increased muscle in the heart that will increase the oxygen consumption. So I'm describing a relatively shy boy. He's a teenager who usually is not able to participate into sports and suffers from effort intolerance of any kind. Let me say there was a football match in his colony and his team was short on one player. So his team members actually told him that today is your lucky day, you get to be on the team. So this guy is very excited because normally his friends make fun of him and they don't let him allow, or rather allow him to play with them because his performance is less. But today they have themselves invited him, so he's pretty excited. He even called his mom or dad that, okay, today I'm playing a football match with my friends, and his mom is very excited too. And she has basically come with her mobile phone and she's making a proper video recording of her son playing football. Now this guy is very excited today, so he is chasing the ball fast. He is trying to run fast just to prove to everybody that, see, I can also run like you. But when he will run fast, he is not realizing that his heart is not designed for this kind of physical activity. He is actually worsening the ischemia which is already pre-existent in the heart, and because of this increase of subendocardial ischemia, this patient actually collapsed on the football pitch. Initially, his friends thought that he had accidentally tripped over, so the match continued. But after a while, the player who was closest to him realized that he has fallen down. 1 minute has gone by, 2 minutes has gone by, he has not gotten up by himself. So his friend called out to him that, buddy, okay, please get up. The match is continuing. We might actually lose because you're lying on the ground. And because he did not get an answer, this friend actually ran up to him. And when he turned him, he found that his lips were totally blue and they had to actually stop the match because this particular individual had died during the football match. Maybe somebody knew CPR also. They tried giving CPR. But when they brought him to the hospital, the doctors had to actually unfortunately declare that this person is already dead. I've given you a scenario of sudden cardiac death during a physical activity like a football match. You can very well understand this is the standard presentation that can be asked in the exam for hypertrophic obstructive cardiomyopathy. But because this question has been asked a lot of times in the exam, nowadays is asking actually why is he gonna die suddenly? Well, I hope you can appreciate this was not a myocardial infarction that occurred in this guy and then he had maybe a severe onset pulmonary edema and expired, because he never cried out in pain. He never complained of chest pain at the moment. All he was doing was running after the ball, collapsed and became lifeless. So what really happened which contributed to mortality of this guy? So your answer would be given as ischemic ventricular fibrillation. You see, once there is a critical hypoxia developing, then there will be a ventricular fibrillation, which means twitching of the ventricle. The ventricle is not going to contract as a whole, it's going to be twitching, and twitching will cause crashing of the blood pressure, due to which unfortunately this person will expire. Usual reason for death in these patients is either a ventricular fibrillation or a ventricular tachycardia. I've written the word PVT to just say it is pulseless ventricular tachycardia. And at this juncture, I also want you to be sensitized to the fact that the arrhythmia which is contributing to sudden death in these patients is obviously ventricular fibrillation. But see the trick he's playing in the MCQ. He's saying what is the most common sustained arrhythmia in a case of HOCM. The technical word is sustained. Ventricular fibrillation is not sustained, man. Ventricular fibrillation per se is going to be like for few seconds and then suddenly the BP will crash, person will expire, and then will be a flat line in the ECG. But sustained arrhythmia, if we say sustained arrhythmia in HOCM it is atrial fibrillation. In fact, guys, I've already explained to you the most common sustained arrhythmia in clinical practice is atrial fibrillation. Whether he mentions HOCM, he says hypertension patient, he says a person of mitral stenosis, in any cardiology scenario, if he says the word sustained arrhythmia, it is going to be atrial fibrillation. If this sustained word is obviously not given and he says that a person was chasing the ball, right, and he suddenly collapsed, then one of the important causes to be answered is ischemic ventricular fibrillation. But if he uses the word sustained arrhythmia, then the answer would be given as atrial fibrillation per se. And at this particular junction, obviously, there is a distinct possibility that his mom and dad of this guy who was brought dead to the hospital might actually come up with this information that even the elder brother of this guy was dancing at a marriage party. He was not even chasing the ball, doing a lot of strenuous activity. I mean, dancing at a marriage party is not a very strenuous activity, and this guy died during dancing in a marriage party. In fact, you would have seen a lot of such videos on YouTube and all this social media where let me say, the bridegroom himself is dancing and he just collapses. That's primarily because of the cardiac issues, that is hypertrophic obstructive cardiomyopathy. So if he himself says the scenario of sudden cardiac death in a sibling, then the differential diagnosis becomes relatively easier for you. I mean, in any cardiomyopathy, there can be sudden cardiac death and there could be a triggered arrhythmia developing. But in HOCM, it is a very characteristic feature where either with physical activity or even like, something like dancing at a marriage party, I mean, not a very strenuous activity, but still, I mean, just putting stress on the heart can actually contribute to death of these patients. In fact, he might change the scenario from football match to, let me say, a basketball match, or he might say that this guy joined a gym, though his heart is not designed for it. And during a gym workout, let me say he and his friends were doing, or maybe his best friend is doing bench press, and his best friend just teased him, "See, I'm doing bench press or twice my body weight. Would you like to try it?" I mean, it's only a game, just a game. His friend said, "Okay, are you game for the fact that let's do bench press or twice the body weight?" And this guy is gonna try it, and he might die in the gym also. And his friend is just hysterical. I mean, the friend is not knowing what really to do. I have highlighted already that in patients who are having a left ventricular free wall size more than 30 millimeter are more vulnerable to sudden cardiac death in these patients. And the question is still open, guys. What intervention can actually prevent this sudden cardiac death? I mean, obviously, one is you diagnose the case beforehand. You obviously then can take preventive steps. But the point is there has to be something that has to dramatically alter the course of the disease once it is diagnosed. This is the usual clinical profile of this patient. We will now talk about what is going to be the examination findings. I'm assuming the fact that this person has presented to me before playing that football match. If he had presented, obviously, if he presents to me after a football match, he will obviously not be able to survive. So now let us look at what is going to be a scenario if this person had presented to you before this fatal event happened. In fact, just to create a scenario like this, I said this particular same guy, he came to me because he wanted a medical certificate. And medical certificate for what? He said, "Sir, I need a fitness certificate because my school in the summer vacations is starting some football or basketball coaching. So my principal has given a letter saying that go and get a medical certificate from doctors, and only then we will be allowing you to participate, because obviously the school doesn't want to take a chance. Or in summer vacation, the school of this guy might be taking him on a rock climbing expedition or any kind of sports activity in which physical fitness is required. And if you are going to give a medical fitness certificate to this guy, and if he dies, then the responsibility is yours." One, at this junction, I want to highlight that never give fitness certificate to anybody, especially don't give it to parents when the child is not there, because lots of time you will be having parents who will be coming to you and say, "Oh, I'm ready to pay your fees, but my child is at coaching, or my child is in school, or he's busy, or he can't come, he has his exams, etc., etc. So please give a fitness certificate." If you give a medical certificate without the patient being physically present, and tomorrow if he dies, it's definitely going to be on you. And this has actually happened. There was a student from a very reputed school in Delhi, and the school had taken this kid out for rock climbing expedition. Now, when he was doing this rock climbing, he died. And during postmortem, it was found that he was having a big heart, and the parents then sued the doctor who had given a medical clearance. Unfortunately, the doctor lost the case because there were a couple of technical issues, and he had never actually examined the patient in the very first place. Had this doctor examined the case and still the person would have died, you can say that, okay, this finding was not there at the moment, nobody can challenge you. You see, there's a difference between missing a finding and not even checking out the finding. If you are going to miss a finding, nobody can penalize you. Like, for example, I'm going to tell you a pulse characteristic of this condition, and if a doctor has never checked a pulse like this before, he might actually miss it. So that is error of judgment. Nobody can penalize you for that. But if you are not going to make an attempt to even physically examine the patient who's at risk for dying, that's definitely amounts to medical negligence. Now, coming back to the agenda, I want you to understand how the pulse characteristics of this patient will be developing, and I want you to look at the waveform of the normal pulse. From your baseline classes, you are anyway aware of the shape of the pulse waveform. You see there would be definitely a convexity because the heart is going to be pumping out blood. So the initial notch that comes up here is called as anacrotic notch, and the waveform that is present at the moment is called as percussion wave. Then is a tidal wave, and then is a dicrotic notch. In fact, I can just hand draw this before you so that it becomes relatively easier for you to comprehend. You see, pulse is appreciated in the phase of systole. So I'm going to just draw a similar kind of a diagram here before you, and then I'm going to highlight this dicrotic notch as well. One, you very well know from physiology that this part, which is called as dichrotic notch, is going to be present right after the second heart sound. You can very well see I've drawn it right after the aortic and the pulmonic valve will close. I also want you to understand that in the early part of the curve recording, I had mentioned regarding anacrotic notch, then was a percussion wave, and then was a tidal wave subsequently. Now let us see what happens in a patient of hypertrophic obstructive cardiomyopathy. Let's just focus on the English words there. The first is the word hypertrophy. Hypertrophy means that the heart can generate relatively more power. So therefore, the pulse of this guy will literally take off like a rocket. You can very well appreciate that normally the pulse is gonna peak bang in the middle of systole, but in this patient, there will definitely be a fast rising pulse. In fact, I can just go back to my previous diagram that I had highlighted before you, and you can see that when the blood will go out of the heart of this patient, unlike a normal patient, where there's gonna be smooth ejection into the aorta, in this patient, when the blood will go out, you can consider this to be like a speed breaker in the heart. There is definitely, I mentioned regarding a tunnel which is created due to systolic anterior movement of the mitral valve. So therefore, there is a slight dip in the ejection velocity. The blood is obviously going into the aorta, but one, the amount of blood going out will be lesser, and there will be a slight dip in the ejection velocity as well, which was the meaning of the word dynamic, because blood is moving at the moment and there's a dip in the velocity. So dynamic left ventricular outflow tract obstruction. I can show this once again in this diagram also. You can see this is like a tunnel, and as the heart will contract, this tunnel will narrow, and therefore there will be turbulence that will be created. So that explains the murmur component and a slight dip in the ejection velocity also when the blood is going out. And if you take a pulse tracing in the patient, then this is how it will appear. The pulse will literally go off like a rocket as I showed. It is a fast rising pulse, but then will exhibit a fall also. It's a fast rise and a fast fall. Obviously the momentum will carry the blood forward. So the similar tracing is almost the same with the dichrotic notch of almost the similar caliber, which is highlighted. I said the momentum is carrying the blood forward, no doubt about it. But I just want to highlight this particular part, that you're able to appreciate that the pulse is gonna first exhibit a fast rise, and then when it's going to eject through that narrow tunnel, you can either call it Bernoulli's effect, or as I was saying, there might be a slight dip in the ejection velocity. So there's a fast fall as well. So fast rise and fast fall is the description of the pulse of this particular individual. And had this person come to me earlier, before he played that fatal football match, I may have been able to diagnose him and would have told him that there is no competitive sports to be played by you. I mean, patients of HOCM are not to participate in any kind of sports related activity, because any kind of physical stress on these patients' heart can contribute to subendocardial ischemia, triggering an arrhythmia which can be really, really lethal. And well, I can say that defibrillator access in India will always be limited. I mean, people who can give CPR will also be limited. So most of the time, these patients, when they reach the hospital post a ventricular fibrillation, they're unlikely to survive. The second examination finding of these patients is very characteristic and is called as double apical impulse. I want you to appreciate that normally the apical impulse, the maximum point PMI, point of maximal impulse, is fifth intercostal space, 2 centimeter medial to the midclavicular line. In this person, you will definitely be able to feel a diffuse apex or a diffuse impulse, in a sense that there's a hypertrophy of the heart. So you might be able to feel the impulse in the fifth intercostal space as well as the sixth intercostal space. But what I mean by the word double apical impulse is that in this condition, there is a left atrial hypertrophy also. That left atrial hypertrophy can actually contribute to development of fourth heart sound in these patients, and that fourth heart sound might actually be felt also. So obviously you will feel the contraction, you will obviously feel the apical impulse, but just before the apical impulse will come, you will feel a second impulse. That actual impulse is coming in diastole. Look at the surprising thing, guys. I'm saying that you will obviously feel the systolic impulse, no doubt about it, but you might actually feel an impulse even in the diastole. Now how is that possible is because I taught you right in the first heart sound topic when I described the heart sound, atrial systole occurs in the phase of ventricular diastole. The atrial systole in this condition is more powerful than what happens in you and me, because if left ventricle will hypertrophy, then there will also be a compensatory left atrial hypertrophy. So the force generated by the muscular or hypertrophied left atria in this patient is responsible for a large A wave, or is responsible for an atrial kick, or I can just say the fact that that would be explaining a double apical impulse. You get a normal ventricular systole, normal ventricular impulse, and you not only get a systolic impulse, but you get a diastolic impulse. So that is why the word is double apical impulse. The impulse is also more diffuse in two intercostal spaces because the heart has become relatively bigger. In fact, in some MCQs, he might say the word heaving apical impulse. So the concept is still the same. The impulse is going to be so powerful that it will lift up your finger. And then we're going to talk about abnormalities in the second heart sound of this guy. The highlight is outflow tract obstruction. Just focus on the English word obstruction and compare with yourself the blood to go out of the heart of this patient. Will it take same time as you and me, or will it take relatively more time? Because there's an outlet obstruction present, the tunnel that are created. As a result of it, the blood will take more time to go out of the heart of this patient. So aortic valve will close late. And if aortic valve will close late, then the gap between the aortic and pulmonic valve closure will become lesser. I've already told you that this gap is approximately 30 milliseconds. But now this gap will become lesser. And if you do not treat this condition, the gap will become even more lesser, 30 milliseconds, 20 milliseconds, 10 milliseconds. So therefore, in these patients, you might actually read this word narrow splitting of the second heart sound. And as you have a narrow split, there is also possibility that A2 and P2 might close at the same time. I mean, aortic valve is coming closer, 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 and then will superimpose. So you will also read the word single S2. And if you do not identify this condition, or if it is more severe than what actually it is, there's also possibility that the same MCQ might write the word reverse splitting of the second heart sound, which basically means P2A2. In you and me, we have a A2P2, but in this patient, it will be a P2A2. That is reverse of what is normally happening. So whenever you read statements like the ones that I've highlighted, especially this term pulsus bispherians and SAM, systolic anterior movement of the mitral valve, you are anyway there at the diagnosis of hypertrophic obstructive cardiomyopathy. All that is left subsequently in the MCQ would be to then identify what are you going to do to save the life of this patient. I want you to appreciate the fact that in these patients, the dicrotic notch of the impulse or dicrotic notch of the pulse tracing will not be affected. It is just the fact that in the systole, there are two peaks present. So lots of time you might read the word twice beating pulse. The concept is that normally the apex impulse, or per se, I can say, when it comes to the impulse of the pulse, that is appreciated max in the middle of systole, but here there are two peaks present. You might actually be able to feel only one peak. How? Because there would be a fast rise and a fast fall. So Harrison has actually used another term to describe this pulse in a relatively casual method, because normally they use traditional Latin words like pulsus bispherians, but he has also used the word jerky pulse to sensitize you to the fact that what you're going to feel, the initial component is going to be a fast rise and a fast fall in the patient. The highlight of the topic is these characteristic terminologies that I've highlighted, and as you continue with your auscultation, you will also be able to hear a fourth heart sound of these patients. The reason for this fourth heart sound is left atrial hypertrophy, because kicking blood out of the heart is not only the responsibility of the left ventricle but left atria also. So in this condition, there's a compensatory left atrial hypertrophy, and atria contracts. Atrial systole occurs in the phase of ventricular diastole. So this forceful S4 might even be appreciated by you in a sense of what I mentioned with respect to a double apical impulse in the patient. And then we will talk about the murmur of this condition, which is again very characteristic. The murmur which is heard in this condition is a ejection systolic murmur. If I draw the configuration will be like this. The intensity will rise and then will fall. You can see the peak of the murmur will come in the middle of systole, and then the intensity of the murmur will reduce. So we are going to be having a ejection systolic murmur, but this murmur will behave opposite of what a traditional murmur will behave. I have highlighted this in the murmurs part also, but let's practice that statement once again. I would like you to stop noting at the moment and just follow my words very carefully. The statement of mine is all murmurs will decrease in intensity. Everything that is being talked about here is the loudness of the voice. All murmurs will decrease in intensity on the following maneuvers: Valsalva, standing, and amyl nitrate inhalation. The common thing between all three of them, Valsalva, standing, amyl nitrate, the common thing between all of them will be that they decrease the venous return to the heart. If you decrease the venous return to the heart, if less blood will come into the heart, the turbulence will also become lesser. There is obviously an exception, and that exception is what we need to remember. Hypertrophic obstructive cardiomyopathy, the intensity will become relatively louder. I will also explain to you by going back in the slide why that is so, but I first want you to appreciate this statement, which has been extensively asked in the exam. I mean, whenever he's going to talk about HOCM, two domains that information that he will himself tell you will be pulsus bispherians and SAM. What he will ask you will mostly be the aspect related to murmur or about the treatment domain of the patient, which is still pending. The point is, all murmurs decrease in intensity except hypertrophic obstructive cardiomyopathy. And why that happens is again because of this tunnel that I've highlighted. I mean, this tunnel is the problematic aspect in this case. As I highlighted, there's going to be systolic anterior movement of the mitral valve. There's going to be a septal hypertrophy. There are two contributors here. The reason for that tunnel through which the Bernoulli's effect would come, or I would say the problem would occur, is because of the hypertrophy as well as the displacement. Now, the red line that I put is basically the diameter of the tunnel at the moment. The message is the message at the moment, and that's a very critical one. So I want you to listen to this with a lot of care. My point is that the volume of blood which is present in the cavity of the left ventricle, if it's more, then this tunnel will get relatively dilated. If the amount of blood in the ventricle is lesser, the tunnel size will become relatively lesser. So volume of blood is per se directly related or proportional to the magnitude of left ventricular outflow tract obstruction. The obstruction is the tunnel that I'm talking about, or the funnel you can call it. The volume of blood is going to be the main determinant. Now, if you are gonna make this person stand, then what's gonna happen? On standing, the venous return to the heart will become less. If less blood will come in the heart, I'm just putting a down arrow to say the volume of blood will also become less. And if the volume of blood here will become less, then this left ventricular outflow tract obstruction, you can see the outflow tract obstruction will tend to relatively increase. Why? Because the volume of blood is lesser. As a result of it, the problem in this patient is that the volume of blood in the left ventricle is going to be directly related to the size of the tunnel, that is left ventricular outflow tract obstruction. The point of mind that I want you to specially appreciate is that if the person will stand, then the venous return to the heart will become less and there would be less blood coming in the left ventricle. So the tunnel size will also become lesser. The outflow tract obstruction, the tunnel size is becoming lesser. And what's going to happen if the tunnel will become more narrow? The turbulence will increase. I repeat the fact once again, if you make the tunnel or slash funnel more narrow, then the turbulence will relatively increase, and that is why I said the murmur will tend to increase in intensity. Let me try to explain this once again to you, though I hope it is clear from the statements. In routine valvular conditions, if less blood will come in the heart, the less blood will cause less turbulence across the valvular region, so the murmurs will become softer. But in this case, the special problem is a outflow tract obstruction slash the tunnel, which I have just highlighted before you. If there's going to be less blood present, then this tunnel will become more narrow. And if the tunnel is narrow, then the turbulence will be more. If the tunnel became more wide, then the turbulence would be lesser and the murmur will become softer. But when I make the person stand, because less blood came in, therefore the tunnel is narrow and the turbulence has increased and the murmur has increased in intensity. So you have to specially remember the aspect of murmur that I have highlighted in this case, and on the basis of this discussion, you can not only diagnose this condition but understand one more important aspect. If in your future career, if you are going to be sitting on medical board and giving medical fitness to guys who are going to be recruited into, let me say, Indian Army, you see, if somebody has to be recruited into Army, Air Force or police force, or even let me say traffic police, you need some level of fitness to be present in an individual. If you allow somebody to become a pilot, I'm not even talking about a fighter pilot, I'm saying somebody who's going to be a commercial pilot in Indigo Airlines or Jet Airways, etc., or Jet Airways is closed down, so let me say SpiceJet. The point is, if somebody has to do these kind of jobs, there's definitively some level of fitness that is required. So before you give a fitness certificate to any of these individuals in your career, okay, you are fit to join, like you are in a government job and you're sitting in recruitment, before you actually put your stamp, etc., you are to evaluate these patients for the following things. First, always check the pulse. It is simply that if you are not able to identify this pulse, or you are able to, let me say, not decipher the subtype of pulse, it is okay. I mean, that is, I would call that a judgment error. But if you don't check the pulse, that is a grave medical negligence. Similarly, you would definitely be able to hear a murmur in this chest, and that would be ejection systolic murmur. You will be able to evaluate the second heart sound of this patient, that is narrow split second heart sound. So all of these pointers when put together, and if there's a family history also, then it's all the more clear. Most of these guys will deliberately not declare their medical history. You see, if he will himself say, no, my elder, if you find in any government job, if you have ever sat in recruitment, you will notice that there's always a big performer in which the health of brother, sister, mother, father is always asked. Because if somebody will himself write, my elder brother died suddenly, my elder sister died suddenly, it is always a cause of concern where you will be at a lookout for a disease. So a lot of these candidates who are applying for these jobs might give a false declaration that everybody in the family is fine, and the end result, you might actually not pay attention, because obviously you thought that everybody in the family is fine, so you neglected this component. But if you are going to identify any of these abnormalities, you have to declare the person unfit for recruitment. And when you do that, this candidate or his parents might actually shout at you, might put pressure on you. They might actually ask some politician to give you a call and say, Doctor Saab, make a fitness for this guy. Do not buckle under pressure, guys, because tomorrow when they will make him do sit-ups, push-ups, this guy heart is not going to be able to take it. He will actually expire. There have been instances when doctors have been unnecessarily harassed by ordinary people because a doctor has declared this person infant on the account of these findings. You see, you can always say advised echocardiography. If he provides the echocardiography report, which is fine, obviously your auscultation finding could have been wrong. But the point is, never shy away from declaring the person unfit if you even have a 0.1%, I would say, suspicion that this person could be having a cardiomyopathy. Because most people in India are not going to declare, they're not going to be truthful, they're not going to tell you regarding the history of sudden cardiac death. I shall now be describing to you regarding workup of a patient of hypertrophic cardiomyopathy. If he says what is the investigational choice for this condition, your answer would be given as transthoracic echocardiography. The findings which can be demonstrated here are multiple. One of them is going to be what I said, even from the pathological domain, banana-shaped cavity of the left ventricle. Another one is asymmetrical septal hypertrophy. The next one is systolic anterior movement of the mitral valve. But one which is important for both diagnosis as well as prognosis is left ventricular free wall thickness per se. Now, there are two cutoffs that I want you to remember in this case. So, first cutoff to be remembered is for diagnosis. That is, if it is more than 15 millimeter, it will be confirming the diagnosis that there is a hypertrophic cardiomyopathy. Second, if this size is more than 30 millimeter / 3 centimeter, then the incidence of sudden cardiac death will dramatically increase, and these patients will be requiring a implantable cardioverter defibrillator. Many times in the discussion, I have asked you this question, that what is the major mortality reducing intervention that you would like to do for these patients. I will explain to you the technical aspects of ICD as we progress, but I've given you the answer already. Implantable cardioverter defibrillator is the major mortality reducing intervention in these patients, considering that if the wall is more than 30 millimeter, the chances of death can definitely occur. Apart from this, even ECG component can be asked. You see, I'm not saying that ECG is diagnostic here. ECG will just tell you evidence of left ventricular hypertrophy. So I'm using this opportunity to once again highlight before you ECG characteristics that determine left ventricular hypertrophy. For this, you will have to first take into consideration the depth of the S wave in lead number V1, and then you need to take the height of the R wave in lead number V5 and V6, and then add the two. If you find that the depth of S wave in V1 or RV5 V6 combined is more than 35 millimeter, it is suggestive of left ventricular hypertrophy. Obviously, the confirmation will come from echocardiography. The third investigation may not be done or may not be, I would say, important from the patient's point of view, because invasive investigations, whenever you talk about them, then a patient might say a big no, or he might just say that I will come but may never come for that investigation. Cardiac catheterization is obviously an invasive investigation, so I said the acceptability of that from the patient's perspective is low, but from the academic domain, yes, it is important. So I will here mention a sign before you, and I want to highlight two cardiac catheterization signs at this moment for cardiomyopathy topic. The first one that I will say will be relatively easier for you to relate to, that is called as square root wave sign. You will notice that in the later part of the discussion, when I teach restrictive cardiomyopathy, square root wave sign will be discussed. Even in constrictive pericarditis, I have talked about square root wave sign. I'll draw and show you the nomenclature of the same as well. But at the moment, what I want you to remember is a very classical name that is called as Bronwald-Marrow sign. Now, when I say Bronwald, then everybody knows about Bronwald, the textbook of cardiology, and then is Morrow, not Marrow, right? It is Morrow. So Bronwald-Morrow sign is a cardiac catheterization finding of hypertrophic obstructive cardiomyopathy, For additional information, if you want to remember, I can just add that this finding is usually seen a post premature ventricular contraction, which can actually result in decrease in the contractility. And you notice that there's a decrease in pulse pressure in patients of HOCM. Already the pulse pressure is lesser. In fact, this pulse pressure will become even lesser on a post PVC. But even if you don't get into the findings present here, I just want you to remember this classical name, that is Brockenbrough-Braunwald sign. The complete name I've already said is a feature that helps you to identify hypertrophic obstructive cardiomyopathy. And now we will talk about the treatment part for it. So implantable cardioverter defibrillator is the main treatment for this condition, but we will first talk about which drug will be recommended for these patients to specially reduce oxygen consumption of the heart. This drug I have discussed even earlier for prophylaxis of cases of migraine. Yes, I have described this drug even in management of control of tremors in a thyrotoxicosis patient, propranolol. The advantage that propranolol will give you will be that it will reduce the heart rate, it will reduce the oxygen consumption of the heart, and thereby reduce the incidence of sudden cardiac death in these patients, and overall the symptom profile of the patient will also become lesser. Apart from this, we can use another drug that can control the heart rate, that is verapamil. You're aware, verapamil will act on the AV node. It will cause prolongation of AV nodal delay. And if you prolong the AV nodal delay, the speed with which the impulses will go down will be reduced. And therefore, as you control or regulate the heart rate, you can control the oxygen consumption in the heart. There's a third drug also which has been shown to improve mortality or reduce mortality in these patients, that is disopyramide. Disopyramide per se is an antiarrhythmic drug. So one, you can obviously understand, as I highlighted, the tendency for arrhythmias in these patients is increased. But studies have shown that apart from having an antiarrhythmic effect, it also has a slight reduction in the left ventricular outflow tract obstruction. So there are three drugs on a comparison basis. The first one, like even if I don't say it, but whatever I write is obviously in decreasing order of importance as is given in the textbook also. So the first answer would be given as propranolol for the patient, and then is verapamil and disopyramide. Disopyramide is obviously added as a backup in the later phases of the disease if the patient is not responding primarily for your treatment. Now, before I add more details here, I'd like to give a clinical case discussion before you. So at the moment, please do not note down and just listen to the clinical scenario that I gave before you. I am an intern. I'm sitting in the emergency department of my hospital when this 20-year-old guy came with excruciating chest pain. I mean, he was literally mooning with pain. This chest pain was present even at rest. So I thought that he has had some kind of a coronary event, and I had learned that I should always give sublingual nitroglycerin to anybody who's having chest pain at rest. So I obviously gave that. The moment I gave sublingual nitroglycerin to this patient, I anticipated that after a couple of minutes, the chest pain of this person will improve. Unfortunately, the chest pain started worsening, and there's also possibility that this person can even collapse. The BP might become unrecordable, and the patient might even die also. Though I said, this is something which is relatively rare, but is distinctly a possibility. So we need to understand what went wrong. I mean, nitroglycerin is a lifesaver drug. No, it reduces the coronary oxygen consumption. It dilates the coronary arteries. It's also a vasodilator. So after all, it is supposed to relieve the chest pain. But in this case, the person's chest pain deteriorated. In fact, the only clinical scenario where chest pain will worsen after administration of sublingual nitroglycerin is what we have studied right now, the topic by the name of hypertrophic cardiomyopathy. And when I say like this, the query of most doctors is, sir, how is that possible? Well, let me just explain this. First and foremost, I have already explained to you in the first slide that in HOCM, the left ventricular cavity size is reduced. This means that already less blood is coming in the left side of the heart, the stroke volume is already less, and if less blood will go out of the heart, the coronary blood flow of these patients is already on the lower side. I repeat the statement once again because it's a diastolic malfunction. Less blood will come in, less will go out, therefore coronary blood flow is already lesser. Now, when I gave nitroglycerin to this undiagnosed case of HOCM, then nitroglycerin is a very good vasodilator. It will definitely reduce the blood coming to the right side of the heart. So the good news at the moment is that the stress on the heart will reduce. But the bad news that will come is that because right ventricular inflow is lesser. If less will come in the right, then left ventricular inflow will also become lesser. Please appreciate the fact that in these patients already the inflow is lesser. If you reduce the inflow, if you reduce the blood coming inside the left ventricle with help of the drug, the arrows that I'm putting in red are the effect of the drug, then this effect of the drug will be added to what is the normal physiology of the patient. I said already in this guy less blood is coming. Now if the the drug will cause a further reduction in the blood supply, then you can very well see a dramatic decrease in the stroke volume, a dramatic decrease in the coronary blood flow, and rather a worsening of the chest pain of the patient. I want you to remember, guys, that a clinical scenario where chest pain worsens with nitroglycerin is only and only the topic that I've explained, hypertrophic obstructive cardiomyopathy. In fact, I would like to give one more example before you so that you can appreciate this aspect relatively better, because this person was having also breathing issues. So I decided to give, I thought, okay, it is pulmonary edema, no? So let me give furosemide to a patient of hypertrophic cardiomyopathy. Now, what will furosemide do? It will cause diuresis from the body. Because of diuresis, the amount of blood coming in the right side of the heart, because obviously water is lost from the body, so right ventricular inflow will become less. If right ventricular inflow is left will also be reduced, and already there is less blood coming in the left side of the heart of this patient. As a result of it, the blood pressure can again crash, coronary blood flow can decrease. So therefore, something as simple as furosemide might actually kill this person. I said, okay, let me try something else. So I decided to give ACE inhibitor to this patient. Now, when you give ACE inhibitor, it will also reduce the preload. And when you reduce the preload, then the amount of blood coming to the right will reduce, left will reduce, and in left already less was coming. You see, routine standard cardiology drugs. Routine standard cardiology drugs are like ACE inhibitor, angiotensin receptor blocker, digoxin, calcium channel blockers. Obviously, the calcium channel blocker that I was using earlier was verapamil. Please appreciate, the calcium channel blocker that I'm now saying is not to be given to these patients. Contraindicated are molecules like amlodipine. You can give verapamil because both are having a difference. No, verapamil mainly acts on the heart and amlodipine acts on peripheral circulation. So per se, I want to highlight that the standard drugs which are taught to you for management of congestive heart failure are absolutely contraindicated in a person of HOCM. What are the drugs that are contraindicated? Well, the first one is obviously nitroglycerin. If you give nitroglycerin to this patient, it's a powerful vasodilator. If less will come in the right, less will go to left, and already there was less in the left. So all the standard drugs that I've written are contraindicated. I've highlighted digoxin at the moment with a double line because that recently came in the exam. The main message I want you to understand from this particular scenario is, if a 20-year-old guy is coming to me with chest pain, it was wrong on me as an intern to think that he's having a coronary event. Coronary event will occur at 60, 70, 80, or maybe even 40s or 50s. Like let me say, recently our top captain, Saurabh Ganguly. Saurabh Ganguly was running on the treadmill in his house, and because he was having this premature coronary artery disease, his father was also having coronary artery disease. Coronary artery disease, man, is so common in India. One of the best captains India has produced, Saurabh Ganguly, he suffered from a cardiac event. He had to undergo a coronary angioplasty. But what I want to highlight from here is that if you are going to be talking about chest pain in an individual in 40, 50 years of age, Saurabh Ganguly is only 48 years of age, then you can think in terms of coronary events. But at 20, coronary event is unlikely. At 20, somebody suffering from chest pain, it is mostly going to be a structural defect in the heart, which I missed in this case. I mean, I should have been wiser, no, at 20. I don't anticipate a coronary artery disease. At 20, I expect a structural heart disease to be present in a patient. And had this structural heart disease, would have suspected, I would have given morphine to this guy. I could have given beta blocker to this guy, but I should not have given nitrates to this chap. It could actually kill this person as well. And there have been instances when, these people have come undiagnosed HOCM and they have died after administration of drugs that we routinely use in our casualty. The routine cardiology drugs that are used for management of heart failure are absolutely contraindicated in this case. And at this junction, I also want to highlight aspects related to sudden cardiac death. You see, let us assume that there is an athlete. He plays for a football club, this guy, and he's playing a football game in extra time. Now, there's a possibility that because in athlete, there is anyway some amount of left ventricular hypertrophy because of the running and the exercise that they do on a regular basis. This athlete, when he's running in the extra time, there is a possibility that this hypertrophied muscle might contribute to kinking of the coronary artery, and this kinking of the coronary artery can unfortunately contribute to death of this athlete. I want to highlight once again, athlete's heart, what you study basically implies that while he was making that dash for the ball and he was running, he was dead tired right at the end of the match, last 5 minutes, he wants to score a goal and he's running crazily after the ball. The stress on the heart can be so tremendous that he might kink his own coronary artery, contributing to a MI. He'll collapse on the pitch and he'll die. So it's not that every death in a football match is primarily going to be related to hypertrophic obstructive cardiomyopathy. It can be athlete's heart as well, and you can differentiate on the basis of the thickness of the wall of the heart. You can evaluate the asymmetrical septal hypertrophy, the systolic anterior movement. Those are the differentiating features. Plus, apart from that, even family history of sudden cardiac death, and a guy who is definitely having HOCM can never ever play at a club level. When I'm talking about club level, like Mohan Bagan or any other team per se, to play that level, you need a certain level of fitness. A guy with HOCM can never ever reach that fitness. So in sudden cardiac death on a football pitch or a basketball pitch, first you should consider athlete's heart. And obviously, if it's going to be like a match in a colony, right, boys playing with the ball around, then it could definitely be a possibility of hypertrophic cardiomyopathy. Let me give you another scenario: mixed martial arts fight. In this mixed martial arts fight, I mean, this is going to be nasty. Like two UFC champions, and well, they have the ability. They're using gloves, but then the fist to the chest can definitely be a strong impact. Elbows to the chest, right? I mean, knees to the chest. So injuries to mixed martial art athletes can be really, really lethal. And this MMA artist, he got a punch to the chest, after which this MMA champ, he's, let me say, heavyweight champion, he collapsed and he died. What could be the cause of death? Then your technical answer in this case would be commotio cordis. Please appreciate that in commotio cordis, there is definitely a history of blunt trauma to the chest of the individual. It is blunt trauma to the chest of the individual. It is not simply that this guy was running after the ball and he collapsed. Please appreciate, athlete's heart, commotio cordis are obviously to be ruled out, and once they're ruled out, then you need to think in terms of possibility of hypertrophic obstructive cardiomyopathy. So do not take this to be the first differential in case of sudden cardiac death. Even the following differentials that I've considered should definitely be taken into place. I will now be focusing on the treatment of choice for a patient of hypertrophic obstructive cardiomyopathy. The main intervention that can reduce the incidence of sudden cardiac death is implantable cardioverter defibrillator, ICD. ICD is such a smart device that it can actually identify the arrhythmia and at the same time deliver a DC shock and terminate the arrhythmia without even the patient being aware of it. One of the important indications when an implantable cardioverter defibrillator should always be deployed is if there's a definitive family history positive of sudden cardiac death, or there is a history of unexplained syncope in the same patient, like he became unconscious last time, luckily he regained consciousness, but this good luck of the patient may not persist in the next event when he has a tachyarrhythmia. I have already highlighted if the left wall thickness is more than 30 millimeter, that is more than 3 centimeter, that's again an indication for putting in a implantable cardioverter 3 defibrillator. So I definitely want you to remember these points. And over and above this, I also want to highlight a surgical procedure which can be done in these patients. You see, nowadays we do not do a cardiac transplantation for a person of HOCM. It is mainly a procedure by the name of alcohol-based septal ablation. Now please appreciate what I mean by the word alcohol-based septal ablation is that you are injecting alcohol into the useless muscle of the septal hypertrophy, so it will increase or improve the compliance of the ventricle. This is what I'm saying. If you look at this hand-drawn diagram that I showed before you, I am saying that we have injected alcohol into the useless muscle, so this muscle will be gradually destroyed. So if I just rephrase this diagram or redraw this diagram, if you destroy this useless muscle because it's anyway not contributing to cardiac contractility, so I hope you will appreciate the fact that as compared to what was earlier, there is a definitive increase in the size of the cavity of the left ventricle. There's a definitive improvement in the compliance of the left ventricle. So if more blood will come in, obviously more will go out. There will be improvement in the coronary blood flow of the patient as well. So the procedure that is recommended for these patients from the surgical domain should be answered by you as alcohol-based septal ablation. Apart from alcohol-based septal ablation, another procedure that can be written in the book is myomectomy, but then you can understand that will be relatively even more invasive procedure that will definitely require a open heart surgery kind of a procedure. So therefore, on a comparative basis, if they talk about surgical procedures which are useful, alcohol-based septal ablation and myomectomy are to be answered. If they simply ask you what is the best mortality reducing intervention, then it is implantable cardioverter defibrillator, and the drug aspects I have already highlighted before you. So though there is a flowchart given in the book, I think I've just summarized and simplified the information, and these are some of the important domains that you should be remembering. Over and above this, I once again want you to be very clear about the fact that why is a HOCM patient dying? I hope you recall that that is ventricular fibrillation. If he says what is the cause of death in commotio cordis, like this mixed martial arts guy got a punch to the chest, it is ventricular fibrillation. If it is gonna be athlete's heart, then yes, it is kinking of the artery. So there's a coronary ischemia that can again trigger any kind of arrhythmia. But as an additional aspect, I want to remind you that if he talks about an alcoholic who went on a holiday to Goa, this is a hardcore alcoholic, boozes like anything, and he went on a holiday and he drank himself to death. Well, guys, I'm talking about holiday heart syndrome. Remember atrial fibrillation? Holiday heart syndrome is going to be characterized by sudden death in atrial fibrillation. The heart will beat very fast, the BP will crash, and this person can die. So, because sudden cardiac death is something that is quite frequently asked, so I thought that I'll just highlight these facts once again. The next type of cardiomyopathy that I'll explain to you is called as restrictive cardiomyopathy and is also referred to as the rarest variety. They can also give you a histopathological specimen where some characteristic features can be seen. In fact, one of the highlights that is going to occur in this disease would be that the atria will be very significantly enlarged. You can see that it is not the ventricles, it is atria that are relatively bigger. Why? Because you are having to work against stiff ventricles. Because when you look at the word restrictive cardiomyopathy, it tells you that there is going to be fibrosis in the ventricular wall and atria working harder than normal. If you evaluate the ventricle wall thickness, especially septum versus left ventricle free wall, they almost look to be of the same size. Even the size of the ventricular cavity looks almost symmetrical. So one of the diagnostic features of restrictive cardiomyopathy is that the size of ventricles is normal, though the size of atria can definitely be increased. Apart from this, lots of time they can combine this with a histopathological image as well. You definitely can see that this image is regarding myocytes, but there is a lot of pink homogeneous material which is present all over between the myocytes, and this is actually the deposition of amyloid. In fact, you are very well aware from pathology that one of the important causes of the rarest type of cardiomyopathy happens to be amyloidosis. Let me just put this down for record. Restrictive cardiomyopathy overall is the rarest type of cardiomyopathy that you will be encountering. One of the highlights or important diagnostic criteria that must be demonstrated both on echocardiography and if the person has expired on a post-mortem, if you want to be sure that this was RCM, there would be the size of the ventricles in this condition should be demonstrated to be perfectly normal, or sometimes you might say non-hypertrophied, non-dilated ventricles. Because when I talk about dilated cardiomyopathy, it's going to be a globular heart, it's going to be flabby heart. In this condition, it's not going to be flabby, it is stiff, it is hard, because there is deposition of various products along with concomitant fibrosis, which results in multitude manifestations that I'll explain before you. But first and foremost, we will compile a list of the various etiologies behind restrictive cardiomyopathy. In fact, you will notice that in the textbook sometimes there is an overlap also. You will notice the same causes given in restrictive cardiomyopathy, the same causes given in dilated cardiomyopathy. That is because sometimes you can have a combination of the two as well. Now, one of the important causes, as I highlighted, was this pink homogeneous material uniformly present, distributed around the myocytes. Because you see, normally when you look at myocytes, myocyte will be like a syncytium, like the inferior image if you look at, you definitely can notice at least some semblance of a syncytium present. But in the superior image, the myocytes look to be damaged. And at the same time, the pink homogeneous material that I was talking about is the amyloid protein. For the second case, I can say that my patient had received radiation for superior vena cava syndrome. Like I can just make it clinical by saying that this person was having a hilar lymphadenopathy, which was secondary to Hodgkin's lymphoma, and you gave radiation to shrink the lymph nodes. The good news is the lymph nodes will shrink, but when you give radiation to the chest, it can definitely damage lungs and cause pulmonary fibrosis. Radiation to the heart can cause restrictive cardiomyopathy, and then a person could be having non-caseating granulomas, that would be sarcoidosis. In fact, sarcoidosis you will read both in dilated cardiomyopathy as well as restrictive cardiomyopathy, because I said sometimes there could be an overlap as well. Similarly, if there is a iron deposition in the heart, the condition that I'm speaking about at the moment is hemochromatosis. It could be primary, it could be secondary. Obviously, in secondary hemochromatosis, the iron load is even much more, so there could definitely be fibrosis developing in the chamber. Then he can mention regarding couple of storage disorders from biochemistry, like Gaucher's disease or Fabry's disease also. Even with respect to storage disorders, again, there can be an overlap present. So really do not bother about per se. Wherever there will be overlap, it is unlikely that he will ask you what a overlapping kind of a condition and select one, whether it is RCM versus a dilated cardiomyopathy. The next important entry to be remembered is connective tissue disorders, and winning the list here is scleroderma. You see, scleroderma is a condition, the name itself is explanatory. No, sclero means fibrosis. You have fibrosis in the esophagus, fibrosis in the kidneys of this person. Fibrosis, in fact, is present everywhere, even in the skin. So you read about leather-like skin. So very characteristic. And fibrosis in the heart would cause RCM. Other conditions that I can just add to this are like polymyositis, dermatomyositis. Though primarily in polymyositis, dermatomyositis, it would be concomitant association of skin manifestations, especially for dermatomyositis like the Gottern papules, etc., that are more commonly asked. Then I'm going to describe a disease which is rarer and is found in the southern part of our country, mainly coastal Tamil Nadu or towards Andaman Nicobar side. That is endomyocardial fibroelastosis. Now, when you just read the name, no, it is self-explanatory that there's going to be fibrosis in the deeper layers of the heart, and this fibrosis can affect conduction system also. So concomitant conduction defects can also be present in the patient. We shall now be focusing on the clinical features developing in a case of restrictive cardiomyopathy. I want to tell you that right ventricular compliance will be reduced and left ventricular compliance will also be reduced, but the symptoms of right ventricular compliance will become obvious earlier. Why that is so is because right ventricle will be having lesser muscle, so even a little bit of fibrosis will affect its functioning, whereas left ventricle being relatively having more muscle and more powerful, so it will require more amount of fibrosis to develop for the manifestations to occur. So I repeat my fact once again, the features of right ventricular compliance being lesser in these patients will appear first, and then left ventricular compliance reduction would be manifesting. Well, one and the foremost would be, since the venous return to the heart is getting hampered, the patient will be having a pitting variety of pedal edema / ankle edema. Even in these patients, there can be development of ascites. In fact, he might start the question by describing ascites component, and that might make you start thinking in terms of portal hypertension. But portal hypertension is usually associated with cirrhosis, and in this condition, you will immediately come to know that the question is not of cirrhosis, because when the compliance of the right side of the heart is reduced, then there would be pooling of blood in the peripheral circuit, which will contribute to congestion of the liver also, and there will be a hepatomegaly. Instead of writing hepatomegaly, he might actually mention right upper quadrant discomfort. But the bottom line is that if it is going to be portal hypertension, then there's going to be a splenomegaly, there would be caput medusae, and moreover, in portal hypertension, the etiology is cirrhosis and not a hepatomegaly per se would not be seen. Similarly, in these patients, since the right side of the heart is affected, the jugular venous pressure of these patients will not fall as it normally does with inspiration. In fact, it might exhibit the opposite finding. The JVP might rise on inspiration, that is called as Kussmaul sign. And in the JVP segment, I have already spoken about it. CRR, constrictive pericarditis, restrictive cardiomyopathy, the topic at the moment, and right ventricular MI are causes for development of Kussmaul sign. In fact, this would be worthwhile to just highlight once again. Constrictive pericarditis, RCM, and right-sided congestive heart failure. Etiologies of right-sided heart failure can be right ventricular MI. It could even be pulmonary subsequently. But once you get this CRR right, that would be reasons for Kussmaul sign, which basically means that there would be, instead of a normal fall of JVP, a paradoxical rise. Let us now see what is going to happen when the compliance of the left side of this person who's suffering from restrictive cardiomyopathy, the compliance part is compromised. There would be pooling of blood in the lungs. The increased hydrostatic pressure in the blood vessels will contribute to pulmonary edema. The examiner can write this pulmonary edema explaining the breathlessness of this person on physical exercise. He might say that he tends to sleep in reclining position, or he tends to sleep with pillows behind his back, because the moment he will lie supine, the pulmonary edema will worsen. So he might write the word orthopnea, or he might just use the classical term that this person is miserable at night, he feels so breathless and suffocated at night. That is paroxysmal nocturnal dyspnea. All these features are going to be features of congestive heart failure, and in this case our findings developing primarily because of the decreased compliance of the left side. And if less blood will come in the left side due to stiffness, then less will go out also. So he will talk about effort intolerance. The physical activity of this person is compromised. The bad news is because of fibrosis in the heart. Now that's important, guys. Because of fibrosis in the heart, there might be activation of the clotting system, and there might be clot formation in the ventricles. The technical term that they use to describe the clot in the ventricles of the heart is called as mural thrombus. And because of this mural thrombus, the clot will be thrown into systemic circulation, and once the clot is kicked into systemic circulation, it can contribute to development of embolic stroke in the patient. I have talked about embolic stroke last time with respect to atrial fibrillation, but today I'm teaching you that even restrictive cardiomyopathy, fibrosis will be the trigger and can contribute to mural thrombus and a bad prognosis in the form of hemiplegia, or depending upon whichever circulation is affected. I mean, if it's a posterior circulation affected, there could be cranial palsy is also affected. Coming to the workup of these patients, the first investigation that I would like to do in this case would be a ECG. This ECG will be revealing evidence of low voltage ECG. Now, low voltage ECG is defined as sum of the R and the S wave in the limb leads to be less than 5 millimeter, in the chest leads to be less than 10 millimeter. Low voltage ECG has also been discussed earlier with respect to, let me say, a person having a tubercular pericardial effusion, because there is water outside the heart, so the voltage will be lesser. Even if it's a person with constrictive pericarditis, the calcium component will reduce the voltage. Then the current topic, restrictive cardiomyopathy, it is the fibrosis component that will reduce the voltage. And even in hypothyroidism topic, I've spoken regarding myxedema coma, and at this juncture I've just highlighted all the important causes of low voltage ECG that you should be familiar with, and this is one of the findings that is seen in this case also. Now I will be doing a chest X-ray. Why it is important to do a chest X-ray in this case is to differentiate this from constrictive pericarditis, which is a differential diagnosis of this condition. See, if it is constrictive pericarditis, there's going to be calcification outside the heart. That calcification per se is going to be visible on a chest X-ray, but in this case, because there is fibrosis, the cardiothoracic ratio will be normal and there will be no visible calcification. Yeah, evidence of prominent pulmonary veins will definitely be there. Evidence of pulmonary edema will be very much present in this condition, but I wanted to rule out the possibility of calcification being visible. In fact, I want you to remember this statement. Constrictive pericarditis is an important differential diagnosis in patients of restrictive cardiomyopathy, and we'll study how to differentiate between the two disorders, and these two investigations are definitely giving you some idea. The next thing to be done for this guy is the investigation of choice, that is transthoracic echocardiography, along with Doppler will also be switched on. Now, when you do echocardiography in this patient, one thing you will always notice is that cavity of the left and the right ventricle will be of normal size. The thickness of the muscles will also be normal. So first and the foremost for diagnosis, you need to demonstrate normal size ventricles. Atria can definitely be increased in these patients in size because they are having to work against a relatively a less compliant ventricle. Now, since I've demonstrated that the thickness per se is normal, I will also be able to switch on the Doppler and notice that left ventricular end diastolic pressure is relatively elevated. Again, I highlight because it is stiff ventricles, that is why the left ventricular end diastolic pressure is elevated, and even in this condition there can be left atrial hypertrophy developing, so you may have a S4 written even in this condition. Now, I did not mention about S4 because that would change the entire domain of the discussion. The main highlight is, how do we identify that this particular case is a confirmed case of constrictive pericarditis? So we need to put the entire data in the right domain. Now, I can also go in for a cardiac catheterization evaluation to be sure about the diagnosis. You can take this to be representation of the cardiac muscle, and the problem in this guy is the presence of fibrosis. So let me by yellow represent the fibrosis present here, and now the blood will come in, strike the wall, but then because of the stiffness present, the blood might actually bounce off from here. So I'm just putting a mathematical sign coming up here, which is called as square root sign. Like I was discussing a cardiac catheterization finding of Brockenbrough Braunwald-Morrow sign for hypertrophic cardiomyopathy. At the moment I have put a relatively common one, that is square root wave sign, which is going to be a feature of restrictive cardiomyopathy. Now compare this with the next sketch that I make before you. You can take this black as the representation of the myocardium per se. Surrounding the myocardium is this red, which is calcification. I am representing a person with constrictive pericarditis with a thick zone of calcification around the heart. Even in these patients, it's a possibility that because of the stiffness of the ventricles per se, the blood might bounce off. So square root wave sign is going to be encountered in both of them. In fact, the findings at the moment that I've highlighted on transthoracic echo, Doppler and cardiac catheterization might be same. So what is the best way to differentiate whether it is restrictive cardiomyopathy, whether it is gonna be constrictive pericarditis? Is this test by the name of endomyocardial biopsy. But when you wanna tell somebody I'm gonna do a biopsy of your cardiac muscle, I mean, you can imagine the fright on the face of a person. He's just literally gonna freak out. He's gonna say, "Sir, are you serious? I mean, you wanna take a piece of my heart?" I mean, for a non-medic, biopsy is taking a piece of the heart. So he says, "You wanna take a piece of my heart, sir? I'm not interested." So that is where technology comes in. So nowadays we use cardiac MRI to differentiate whether it is going to be fibrosis in the wall slash calcification outside the heart. Obviously, MRI will have sufficient amount of resolution to demonstrate between a calcification versus the fibrosis present in the wall. So if he says per se that what is the gold standard test on the basis of which you can differentiate whether you are dealing with a case of restrictive cardiomyopathy versus that of constrictive pericarditis, obviously the first answer, the best answer is endomyocardial biopsy. But if he just makes it easy for you by saying that what is the imaging modality which will be preferred to differentiate between the two scenarios and confirm the diagnosis as well, it is going to be answered as cardiac MRI. Now we come to the treatment part of this person. Because these patients will also have tendency to develop arrhythmias, so implantable cardioverter defibrillator would be required for these patients. Over and above this, because there is chances of thromboembolism, so warfarin will be started. We should also start these patients on the lowest possible dose of diuretics, because you see ultimately the filling of ventricles is compromised in these patients. No, if the input is less, output is anywhere less. So if you give too much of thiazides, that may actually cause a hypotension of severe variety in these patients, and we obviously need to put up this patient for cardiac transplantation. I mean, the best way for managing this patient is cardiac transplantation. Though pending a transplantation, we can increase the longevity by doing all the steps that I've highlighted. And when it comes to drugs per se, the only drug that we will use in this case would be thiazides, mainly because I want to reduce the ankle edema component. I want to use the pulmonary edema component, but I really cannot be aggressive with the drugs, because the more I increase the dose, because the drugs will reduce the preload and the afterload also. If I lose the blood pressure of this person, if I cause postural hypotension, the problems would rather be amplified rather than getting improved, because there are so many of them. You can see the function of both the left as well as the right ventricle is getting compromised, obviously serially. But once the patient comes to you, it would obviously be in later stages combination of the two. If he comes early, then it would initially be a right ventricle compliance that is lesser, and the peripheral findings in the form of 1, 2, 3, 4 that I've highlighted before you. The next type of cardiomyopathy that I'll be explaining to you will be having an enlarged globular heart, and because of the change in the shape of the heart, the hemodynamics will also be lost. In fact, this person would be having a thin-walled, flabby heart per se. So we're going to talk about now dilated cardiomyopathy. If they ask you what is the number one cause for development of dilated cardiomyopathy, the first answer is, however, familial, because in 35% of the cases it would be having a genetic basis, but then it could be idiopathic as well. But I'm not putting any number before them to mainly highlight that familial and idiopathic are something which an examiner will definitely not be interested in, because they're relatively easier for you to answer. I just mentioned the prevalence here. Familial would be 35%, idiopathic would be approximately 20%. You are not supposed to note it down or remember, because this is too easy. Most of the time in the exam, he would like to start from what I'm saying as point number 1, that is viral myocarditis. Now, please remember, when I say viral myocarditis, lots of time, because this person might be having even a concomitant pericarditis component, he might be erroneously started on steroids. You can understand in a setting of a viral infection, if steroids are given, then they can be mayhem and they could be a definitive damage to the cardiac muscles. The best example I can give you as of now is COVID-19. You are very well aware of cardiovascular events that are occurring post-COVID. Lots of patients of COVID-19 are anyway on steroids, especially if they're having the severe variety, and the end result of this steroid which is given during a viral infection can be that it will potentiate whatever damage the virus is causing to the heart. So lots of patients of COVID-19 myocarditis are now actually developing dilated cardiomyopathy in the subsequent scenario. The incidence of viral myocarditis is definitely lesser as compared to what I mentioned earlier, but this is what the examiner usually wants to hear. I also want to remember that when it comes to the viruses which are mentioned per se, one of the important viruses is human parvovirus B19. Yes, the same organism that we have talked about for development of aplastic crisis in hematological problems like sickle cell anemia, hereditary spherocytosis. It also causes development of slapped cheeks appearance. That would be fifth disease. But today I'm talking about the same organism contributing even to the myocarditis component and a sequelae of that as a dilated cardiomyopathy. The next virus to be remembered in series after this is HHV6, and then would be Coxsackie. You see, why I'm highlighting that is because when I was a student your age, my primary input that I used to study was that Coxsackie B myocarditis is the number one cause of viral myocarditis. But as of today, you would have seen in the books that parvovirus is given before Coxsackie. There's a flabby heart, there's a globular heart developing in this patient. So he will ask you which toxin can contribute to it, and long-term alcohol intake can again contribute to this. The prevalence of toxin-induced cardiomyopathy, that is DCM, is relatively 20%. But then again, it is the question will specifically mention toxin per se. If he talks about non-infectious cause, then another important one to be remembered is sarcoidosis. In fact, a lot of cases of sarcoidosis per se can be having a combination of dilated cardiomyopathy as well as restrictive cardiomyopathy. A combination is definitely possible. And then he can also incorporate a pediatric example, Duchenne's muscular dystrophy. You see, Duchenne's muscular dystrophy will be having a defect in dystrophin gene, which is one of the biggest genes. The message at the moment is that in Duchenne's muscular dystrophy, not only do you have problem with skeletal muscle, which contributes to battling gait and pseudo hypertrophy of calf muscles and Gower sign and difficulty in getting up from sitting position on the floor. Over and above this, even it is the cardiac muscle that can get involved in this condition, and the manifestations of dilated cardiomyopathy and heart failure can occur. And I have described in myopathies and especially Duchenne's muscular dystrophy topic primarily that the leading reason why Duchenne's muscular dystrophy patient will die is because of congestive heart failure. As I highlighted, in this condition, the heart will be thin-walled, it would be flabby heart. In fact, that is one of the diagnostic criteria of this condition. In all the previous scenarios, I was talking about either an increase in the thickness of the walls, or I was talking about normal thickness of the walls. Increased thickness for HCM. When I spoke about restrictive, it was normal thickness, but with obviously an intervening fibrosis. But at the moment, I'm highlighting that you need to demonstrate decrease in the thickness of the wall in the absence of other common etiologies. One of the reasons why heart wall can become thin is because of ischemia. So you obviously need to rule out the possibility of triple vessel disease or ischemia present in the patient. Otherwise, I will call it ischemic cardiomyopathy. Now, I'll not call it a dilated cardiomyopathy. So you need to rule out that this person has ever had any kind of infarct or is having a triple vessel disease or coronary ischemia. There is no hypertension present in this guy. There is no valvular heart disease present in this guy. So if you ruled out all the common reasons why the heart wall is damaged, repeat the fact once again. If you rule out the common causes because of which the heart wall is damaged, then subsequently, because the thickness of the wall of the heart will be substantially less in this case, that is when we're going to think in terms of DCM as a problem. And one of the problems that is very commonly encountered in these patients is a functional mitral regurgitation and a tricuspid regurgitation, because the valves will become dilated. Now, because these valves will become relatively dilated, there's a functional TR or MR, so pansystolic murmur can be described, and you can well understand this regurgitation will not only contribute to pulmonary edema component, it will not only contribute to peripheral edema or ankle edema component, it will also worsen the heart failure, because after all, when you have regurgitation of blood from a high pressure to low pressure chamber, there's going to be further distension of the chambers of the heart. That is why I highlighted that there is a change in the hemodynamics, because I am describing a globular heart. It is a gross change in the shape that will cause the normal hemodynamics to be affected. Let us now look at how the clinical case on this topic would be given to you. He can actually mention the trigger, that is alcoholic. He can say that this guy is a hardcore alcoholic and has been boozing for last 20 years. And now the end or the bad news is that he's having features of right ventricular failure. He'll obviously not say right ventricular failure. He'll just say that this alcoholic has today presented with extreme swelling in the feet by which he's not able to wear his shoes, or he's having right upper quadrant discomfort, which you can decipher is because of the hepatomegaly, the component that would come up in this guy. And as there's going to be left ventricular failure, then dyspnea on exertion, features of pulmonary edema that have been discussed multiple times, ranging from orthopnea to PND can be given. There can be exercise intolerance developing in this person. So initial features are going to be just like that of heart failure. Now, what is going to be written in the question that will immediately tell you that this question is not of a standard heart failure but is of DCM per se is the next word that I say. For this, I want you to at the moment listen to my words very carefully. Please stop noting and listen to the input that I say. This is the representation of the normal pulse waveform. We have an anacrotic notch, then we have a dicrotic notch. I've already told you the dicrotic notch will be after S2, and then this component falls. you will notice when this component is falling, it is not going to fall immediately, it's falling gradually. This component actually is dependent upon the peripheral resistance that is present in the body. Now, because in this condition there's going to be dilated globular heart, there's definitely going to be a decrease in cardiac output. If cardiac output will decrease, the RAS system will be activated. This is going to upgrade the peripheral resistance, and therefore this component where I have put the star mark, or just this area where I'm putting double star mark at the moment, this component, it may not fall immediately because the peripheral resistance is upgraded. So if you're gonna evaluate the pulse of this guy, you will notice that the rate of rise of pulse will be the same. The amount of blood going out of the heart is obviously lesser because the heart is damaged, but I want to highlight that this pulse will rise like a normal pulse, but the amount of blood going out is lesser. And then if you look at the tracing per se, it looks as if the dicrotic notch has become bigger. Please appreciate, it is not the dicrotic notch that has become bigger where I put the star. It is not the dicrotic notch that has become bigger. It is the peripheral resistance which is relatively upgraded. So this column becomes relatively big, and therefore the two peaks that are appearing at this moment are almost of the same height. Well guys, I am teaching you about something which is very peculiar. I'm teaching you about a twice beating pulse. I taught you about a twice beating pulse in systole, that is pulsus bispherians, but look at the surprising thing that I'm teaching you. In persons of dilated cardiomyopathy, you can feel the pulse, the impulse not only in systole but even in diastole. Now that is very shocking because traditionally we read that pulse is going to be present only in systole. This twice beating pulse, which is felt both in systole as well as in diastole, is the key word in the question and is called as dicrotic pulse. So that's one of the good pickup points in the MCQ, because the moment you start reading this, you know that you're dealing with a case of DCM. Over and above this, he can obviously give findings which are traditional ones, like he can talk about loud S1 if there is a heart failure. If it is chronic MR in these patients of the functional variety, then it can be soft S1. So either of the two can be given. I repeat that again. If he goes into full-blown heart failure, they would be loud S1. If it's just a chronic MR which is compensated at the moment, then there can be a presence of a soft S1 in the patient as well. There will be also mention of pansystolic murmur, which will be present due to a functional MR and TR in this case. Then even he can talk about findings of left ventricular failure like a narrow split, second heart sound, third heart sound present in this patient, bilateral fine crepitations present. So remaining findings you might even encounter in heart failure. But if you read about the murmur to be present in these patients and you read about dicrotic pulse, then obviously you need to think that I'm not dealing with a standard case. If he wants to help you, he might even say the word hypokinetic impulse, because you see the heart wall is flabby, it is thin, so the impulse delivered to the chest wall will be lesser. So it will be a hypokinetic, and it will definitely be a diffuse and a laterally displaced apex. I repeat the fact once again. Hypokinetic because the power generation is lesser. Diffuse because the heart is relatively bigger. And therefore he might just say hypokinetic, diffuse, laterally displaced. That's again because of the enlargement of the heart per se. Laterally displaced point of maximal impulse that you feel with respect to the apex beat of the patient. So some of the features I personally feel are relatively easy to pick up. Let us now look at what will we do for the workup of these patients. Well, the standard answer will be echocardiography. Transthoracic echo is the investigation of choice for this condition per se. You can evaluate the functional MR and TR. If you do chest X-ray in this chap, you will definitely be able to demonstrate a cardiomegaly. The CT ratio will be increased. Pulmonary edema component in the form of prominent pulmonary vasculature will definitely be demonstrated in this patient. And you can be sure about your diagnosis by doing a cardiac MRI in these patients. In fact, if they ask you overall what is the best way to identify any type of cardiomyopathy, then overall the best imaging, like what I'm saying is echo is also given and cardiac MRI is also given, though most of the time we are doing a echocardiography only in the patient because that is what is available. But if he wants to talk about imaging from radiological domain, lots of time cardiac MRI may not be available. As a result of it, the preferred answer, the first answer in the question, because of lack of availability, is what I was saying initially, echo. But if he's going to compare the two, then cardiac MRI, because see, cardiac MRI can pick up hypertrophy, it can pick up fibrosis, it can pick up calcification outside the heart, it can pick up thinning of the wall of the heart. It will be relatively more accurate. And obviously I can mention a traditional method also, endomyocardial biopsy. You can understand the reservations on the part of the patient. I mean, he may not agree to the fact that you want to do a biopsy. So I would like to highlight or answer in the following sense. If he says what is the gold standard investigation to differentiate between different types of cardiomyopathies, especially from pathology domain, like let us say the patient has expired. then it really does not matter for all these investigations. Now we are obviously taking or making a specimen, or we are taking a slide from the specimen and we are evaluating the patient. You see a couple of slides I have shown highlighted earlier also. I would just like to bring them to notice once again. If you look at this image per se, one, I want to highlight that you definitely can see the myocytes, you can see the syncytium present, but in some areas the myocyte damage is definitely seen, and most importantly you can see these big nuclei. These big nuclei, I would like to call these as multinucleated or multinucleated myocytes. So in dilated cardiomyopathy, what is the finding present is what I've highlighted at the moment. If you do a biopsy, I mean, if a person is alive and he is agreeing for this biopsy, great. Otherwise, most of this would be done after the death of the patient. Myocyte damage with multinucleate myocytes is a feature that is encountered in dilated cardiomyopathy. In restrictive cardiomyopathy, I've already told you there would be pink hyaline eosinophilic deposit between the myocytes. And now look at the last one. There is huge number of myocytes present, so we call it myocyte disarray. This myocyte disarray is a feature that is encountered in hypertrophic obstructive cardiomyopathy. I did not mention that earlier because in clinical practice it is not a biopsy report that we're dealing with, it is an actual patient that we're dealing with. So these findings can be collaborated from that of pathology. But if you can just take a snapshot of this part and keep it in a mobile and revise it again, I'm very sure if they give you a pathological correlate, you would definitely be able to pick it up. I highlighted that cardiac MRI per se will be the best way to evaluate any kind of pathology in the muscle, outside the muscle. That is constrictive pericarditis can also be ruled out because that's a differential or restrictive cardiomyopathy. So if they say what is the best imaging modality, cardiac MRI followed by a transthoracic echocardiography. Now let us look at what is the treatment options that I can offer for this patient. Well, in this case, we will definitely deploy a implantable cardioverter defibrillator. The advantage of ICD is that it will terminate any tachyarrhythmia. Another problem in these patients is that the left and the right ventricle do not contract together. There's a possibility left will contract first, then right, vice versa. Because of this disharmony, because of the lack of synchronicity, because of the lack of coordination between the left and the right ventricle, again they can be pooling of blood in the lungs. Guys, in you and me, the left and the right ventricle fire exactly at the same time. That is why the circuit is maintained. Imagine if both of them are having a time lag of even 0.01 second. The bad news will be pooling of blood in the lung circuit that will contribute to pulmonary edema. So in lot of these patients, you will notice that because of the asynchrony, because you see left ventricle wall may be more flabby than the right one. It could be right ventricular wall that could be more flabby than the left one. Because of a flabby wall, the simultaneous synchronous contraction that should occur during ventricular systole of both of the ventricles is not going to be in harmony. So to ensure this coordination, we will have to deploy some electrodes. These electrodes will stimulate the heart in such a fashion that both ventricles will contract in synchrony, in harmony. Therefore, this is called as cardiac resynchronization therapy, CRT. I want to highlight the fact that cardiac resynchronization therapy, as the name suggests, is different from implantable cardioverter defibrillator. ICD, what it will do, it will detect abnormal rhythm. And once the abnormal rhythm is detected, it will then deliver a DC shock, and it is goodbye to this arrhythmia unless and until it shows up again. Again, it will deliver a DC shock. But in cardiac resynchronization therapy, what you are ensuring is a proper cardiac output, a reduction in the pulmonary edema component due to simultaneous firing of both the left ventricle as well as the right ventricle of the patient. So that is very important that I want you to understand. Obviously, drug support I will use. I'll not prefer to use AC inhibitors, ARBs, because blood pressure might be lost already. Their left ventricle function is compromised, so they could be having hypotension. So I will be using rather oral thiazides very judiciously in the lowest possible dose. I want to teach you that out of all the causes of cardiomyopathy, if they ask you which of the following cardiomyopathies is the leading cause of cardiac transplantation, please remember, overall the commonest type of cardiomyopathy as far as Harrison is concerned and most of the pediatric textbooks are concerned is going to be hypertrophic, not dilated. In Robbins it might be mentioned dilated, but overall it is mentioned as hypertrophic cardiomyopathy considering the incidence and prevalence of the disease. So there are two aspects. Overall cardiomyopathy that is encountered is hypertrophic when we compare with dilated versus restrictive. Rarest is obviously restrictive, no issues, but if they say which of the following cardiomyopathies is going to be having a requirement of transplantation, then the leading leading cause of cardiac transplantation is the topic that I've just explained, that will be having a dicrotic pulse, a twice beating pulse with a peak in both systole as well as diastole. And if he says that which subtype of it will be causing a good prognosis or which will be causing a bad prognosis, then I also want you to remember the following terms. Though this is mentioned even in OBGY, I would just like to highlight one of the rare causes of dilated cardiomyopathy, which is called as peripartum cardiomyopathy. Let's look at the definition, guys, because the word is peripartum. Therefore, it means that it would be developing with respect to our delivery. So if you read a cardiomyopathy or heart failure findings which are developing in the last month of pregnancy, we have ruled out anemia, we have ruled out valvular heart disease, we have ruled out eclampsia in this lady. I mean, she's not having any pre-existing cardiac condition. It is just suddenly that in the last month of pregnancy, cardiovascular symptoms are starting to develop in this patient in the form of breathlessness. Initially, the lady thought that it is because of pregnancy, but then her symptoms have been progressively increasing, and when you did an X-ray or when you auscultated her, they were bilateral fine crepes present. If you are having congestive heart failure findings in the last month of pregnancy and up to 5 months postpartum, in some books it is given 6 months also, but I would just like to quote what is given in some of the books. Last month of pregnancy and 5 months postpartum, total duration is taken to be 6 months, but because it is called peripartum, so they're taking 1 month from actually the delivery of the lady. That is, either it is last month of pregnancy or 5 months postpartum. Now, why am I discussing this OBGY causes? Because you definitely can have a recovery in this case. So if he says which cardiomyopathy can be having a best prognosis, then the answer is not to be mentioned from any of the previous terms that I've used. It is peripartum, and the presentation of peripartum cardiomyopathy is same as that of DCM, dilated cardiomyopathy. In contrast, if he says which cardiomyopathy, just general, which cardiomyopathy has the worst prognosis. Now here I'm not only talking about the ones that I've already discussed with you. I want to say that suppose a person is having triple vessel disease and person did not get surgery done, like a diabetic patient with diffuse triple vessel disease, then even CABG cannot be done, because every 1 centimeter, every half centimeter, there is a atherosclerotic plaque causing 80-90% blockage. So how many bypass can you put? There's a limit, obviously, no? So in persons of triple vessel disease, if it is a diffuse disease, they can be a ischemic cardiomyopathy, because now the supply to the heart is less. This ischemic cardiomyopathy overall will be having a worst prognosis. So I've just added 2 questions here. Which cardiomyopathy has a relatively good prognosis? Or among, I mean, cardiomyopathy is always bad, guys. I mean, my point is only in relative sense. Which has best prognosis? Peripartum. Which has a bad one? It is ischemic. And most of the time, the questions that are asked are even from etiology domain. So you can brush up this topic from pathology, in fact, first, and then you can listen to the aspects that I've highlighted. And out of these 3, if you say one that I should always revise in last 1 month before the exam, that is HOCM. I mean, that's a standard feature which has been asked. But as I forewarned you, I mean, don't jump the gun for every football death being due to hypertrophic cardiomyopathy. Take a look at the question. If it is punch to the chest, if there is violence in sport, like a guy headbutt the other guy, headbutt to the chest, commotion caudius, no, then the situation will change, guys. So I mean, I hope you will be able to evaluate on that very fraction of a second that okay, this doesn't look to be a presentation of HOCM, so just to keep a watch on that. So these are the details, guys, that I would like you to remember for this topic. Keep hammering, keep learning, and I'll definitely see you with another topic.